Well, good afternoon, and I want to thank the organizers for inviting me. I am a professor of child neurology, so I'm a clinician and a physician researcher. I come from Wisconsin, and I'll talk about epileptogenesis, which myself and my colleagues are very interested in terms of research, and which we think would potentially be a topic of collaboration with MIPT. So let me start with definitions. What is a seizure? Seizure is an abnormal paroxysmal change in the electrical activity of the brain, and epilepsy is a neurological disease. It's a disorder, it's a brain state that supports the generation of recurrent and unprovoked seizures. And epileptogenesis is something I will define, but first I want to tell you what causes epilepsy. Well, we have situations where the epilepsy is the endpoint of acquired brain pathology, such as tumors, infections, traumatic brain injury, stroke, bleed, and the list is not complete. Or the epilepsy can be the result of a mutation of a single gene, and in these cases we speak of genetic epilepsies. Now, epileptogenesis is the process by which the brain is functionally altered and primed towards the generation of recurrent seizures, and it may take months to years in a human from the time of the initial insult until the time when the seizures start. Fact is, we have lots of drugs, diets, surgical and non-surgical options to treat epilepsies, but we have absolutely no treatments to prevent epileptogenesis. Is the development of anti-epileptogenic treatments worth investing in, and is it a good thing to do? And I want to show you a few facts why that is the case. Now, epilepsy is a devastating illness to have. It occurs in up to 2% of the population. Around 50 million people worldwide have active epilepsy, and unfortunately 30% of the patients are drug refractory, so we cannot treat them properly. The European costs per year for the treatment of epilepsy, 20 billion euro, and the disease is associated with high social burden, psychiatric comorbidities, and an increased risk of death. Now, who is at risk for developing epilepsy? Well, much larger numbers of people, obviously. So patients with stroke, traumatic brain injury, brain tumors, infections, systemic diseases. And let me just touch upon the stroke and the TBI. So cerebrovascular events, or stroke, as you know, is an acute neurologic deficit that happens because of a bleed in the brain, in which case we talk about hemorrhagic stroke, or due to shutting off of the brain circulation because a vessel is occluded. And in this case, we talk about ischemic stroke. And fact is that 1 in 6 people in their lifetime will have a stroke, and 11.6% of them will develop epilepsy. But when we look at specific age groups, the very old ones and the very young ones, these numbers are much higher. For example, among children with stroke, the incidence of epilepsy later in their life is 54%. Now, traumatic brain injury is a high burden in our society. We don't know the exact numbers of traumatic brain injury, but in the United States, about 1.4 million people will seek medical care because of traumatic brain injury, and about 280,000 will be hospitalized. And among those, the risk for developing epilepsy is very high. For example, in this study where about 6,000 cases were followed over 10 years, in the patients with a severe traumatic brain injury, the likelihood of developing epilepsy was 17 times higher than in the general population. So what are the targets that we want to pursue? There are several, but I'll just highlight two of them. Target one is to inhibit proteins of the extracellular matrix. And our target number two is to reduce connectivity of neuronal circuits in the brain. Now, what is the extracellular matrix? That's the space in the brain that's outside the cells. And in this cartoon, it's blue colored. So we have the cell membrane, the inside of the cell, and the outside of the cell, which we have come to learn that it is a very active space and accommodates a large amount of proteins and actually plays key role in the development of epilepsy and in the process of epileptogenesis. And in this extracellular space, we want to target one particular class of proteins that has many members, the so-called matrix metalloproteinases, which are depicted here in orange color. We know 13 members of this family, and we know that these proteins are normally inactive, but then when they get activated in the context of injuries, they can degrade a large amount of extracellular proteins, change the morphology of synaptic connections and neuronal processes, disrupt the blood-brain barrier, and cause epilepsy. So target one is actually to develop the potential of matrix metalloproteinase inhibitors, so medications, to prevent epileptogenesis in animal models of acquired epilepsy. And the translational potential of this approach is actually very high. Why? Because there are already licensed drugs that are used for other indications, for example, for blood pressure control, that one could potentially use, but also because there are large libraries of compounds which inhibit these enzymes and which have been developed primarily for the treatment of cancer. But unfortunately, the clinical trials in cancer were negative. So these compounds could potentially be repurposed if our principle proves to be correct. The second target is based actually on a hypothesis that has come out from computational neurosciences. And my dear colleague, Dave Su, who is also a child neurologist and computational neuroscientist, along with his wife, Marielle, have used computational models to actually come to this conclusion. And the conclusion is that brain stimulation will prevent the development of epilepsy because it will increase baseline activity of neurons within neuronal networks. And I'm not going to go over this in detail, except to say that what we want to do is to apply transcranial and intracranial brain stimulation, and that is electrical stimulation, in preclinical animal models of epileptogenesis and evaluate their anti-epileptogenic efficacy. Now, I will skip this. Translational potential, it is also very high. We already have methodology that allows us to non-invasively stimulate the brain. And this is one of these approaches which we consider to be particularly promising as an anti-epileptogenic approach, transcranial direct current stimulation. The principle is very simple. We apply two electrodes on the scalp, an anode and a cathode, and we connect them to a 9-volt source. And this induces electrical fields on the brain, which can be inhibitory or excitatory, and which can alter neuronal excitability. And in fact, there's a great interest in this technique. In fact, next week I'm going to a meeting in New York which focuses exactly on this one method, the high-definition transcranial direct current stimulation, which uses several electrodes which apply currents that can be targeted on specific areas of the brain that are of interest and which can be modulated in the way we want. So to summarize on this, we consider that the translational potential of brain stimulation in the prevention of epileptogenesis is very high because we already have non-invasive techniques such as high-definition transcranial direct current stimulation, which is used worldwide, both in Europe and in the United States, in clinical trials for rehabilitation purposes from stroke and traumatic brain injury. And so prevention of epileptogenesis would be an excellent target for further development and licensing of high-definition transcranial direct current stimulation. And engineering is needed here. So we want, in summary, to provide preclinical proof of principle and evaluate the potential of drugs, specifically matrix metalloproteinase inhibitors, and transcranial direct current stimulation to prevent epileptogenesis in animal models of chemical-induced epilepsy, electrical-induced epilepsy, and post-traumatic epilepsy. And if we are able to actually prove that these principles, or one of these principles, is correct, then we can translate. We are a big neurology faculty. You just see part of us there in that picture. We have 42 neurology faculty with an expanding epileptology faculty, adult and pediatric. We have adult and pediatric epilepsy monitoring units. We have the excellent support of the NIH-funded Institute of Clinical and Translational Research and excellent clinical research facilities. Thank you for your attention, and here are some pictures from where I come from.